From alliance ruptures to therapist humility, certain moments in therapy can make or break the work, yet most of us have little training on these pivotal moments. In this conversation, Dr. Michael Constantino lays out his vision for a new era of therapist training, one that's evidence based, responsive, and highly personalized. I'm your host, Dr. Dan Cox, a professor of counseling psychology at the University of British Columbia, and welcome to Psychotherapy and Applied Psychology, where I dive deep with the leading researchers to uncover practical insights, pull back the curtain, and hopefully have a little bit of fun along the way. And please feel free to leave a comment below. And if you enjoy this conversation, it'd be appreciated if you hit the like button and subscribe to the channel. So without further ado, here's my conversation with Dr. Michael Constantino.
So we're also working on an app that allows patients to sort of drive their own matching right on their phone, where it sort of populates in a given area. Here are all the therapists that, once a baseline has established their effectiveness profiles, these are all the therapists that show up for you in your filter. And depending on what else is important to you, preference wise, you can start clicking on other boxes like I want them to be within 5 miles, or I need it to be virtual, or whatever. And that short list will shrink. But eventually, here are the people that are well matched to you, meet your preferences, and you can get on all of their wait lists simultaneously, and you'll get a ping when the first one has an availability. Right. So that we have some funding from NIH now for a small business innovation research grant to test this app, which puts the patient right in the driver's seat as opposed to an intake coordinator or an administrator.
Right. So
Yeah.
I want to get back. There's so many things I want to hit, but because I think it sort of feeds into what we were just talking about.
Yeah.
I want to bring in sort of the deliberate practice idea here,
Yeah.
and
Yeah.
particularly what you brought up, which is you have a center, a network, whatever, and there isn't anybody who's particularly stellar in this area. So I'm imagining where you have one or two or three therapists who are like good, not great. And I'm
Yeah.
thinking, like, is that potentially a place where one could bring in deliberate practice to try to help get a person into that great category?
Yeah, I think it's a great question, and a testable one, and one that we want to pursue. I mean, I think as you likely know, the connection between deliberate practice and therapist effects has been that there is at least one study out there that said one thing that predicts higher performing therapists. This is on the global between therapist effect. One of the things that predicts that is that they are more likely to engage in deliberately practicing their craft, whether that's watching videos, working with peer consultants. They really try, and especially between sessions and between work with patients, they really try to sort of work on their craft. And so that made this connection between deliberate practice and therapist effects sort of be more high profile. For us, there's also, I mean, deliberate practice is really just a method of learning. And I would say overall, the research is promising, but still mixed. I think sometimes the effect of deliberate practice as a method can be overstated, but certainly there are studies that exist that say, and we did one, for example, we did a deliberate practice workshop for helping therapists become better at addressing resistance in the room. And it turns out that after this workshop, when you measure things like therapists' ability to use empathy and to roll with resistance and to be validating, all things that research tells us will help you better resolve patient resistance to a treatment or provider. Therapists can learn those things in a relatively sort of effective way. And so we would like to take that teaching and learning technology of a deliberate practice type workshop, have those become continuing education experiences that, at least connected to our trial, focus more on the type of presenting problem a patient has. And that gets challenging, right? Because it's probably not going to just be you have to learn a manualized treatment for that disorder. Right? But it could be that there are nuances of the research for treating people with depression or anxiety or substance misuse that a deliberate practice workshop can focus on. And for a therapist whose early profile said, you are kind of ineffective or weak in this area, and they're just like, but I don't want to give up on that, on treating patients who have that concern. Maybe after a series of deliberate practice workshops and targeted continuing education, maybe their next profile will show that they're up to average, maybe some could even work it into a strength, right? But it all takes sort of intentionality that comes from learning in an evidence-based way what your strengths and weaknesses are. And I think what might help that, I think what's really interesting about that study we talked about a while back, where we showed therapists weren't particularly good at predicting their own effectiveness, strengths, and weaknesses. The thing that um, the one of the things that predicted actual therapist performance was the therapists who underestimated their abilities were actually the therapists who overall on the global top score, their average patients did better than other therapists. So there is a certain level of humility that we also know. If you are a humble therapist, you are probably more likely to be an effective
And why do you
therapist.
think that that is?
Yeah, I think part of it is a willingness to the connection I wanted to make was that if you knew of that finding, then you might be signing up for or going into these deliberate practice workshops with an attitude of like, I have a lot more to learn. It is a lifelong learning career. It isn't that I've, somehow um, learned how to do these three treatments and I'm just going to do them over and over again, right? I think humility breeds flexibility. It breeds openness to learning. And then if you can plug that into another factor like deliberate practice that is also predicted between therapist effectiveness differences, if you combine the virtue of humility with the openness to engage in deliberate practice, maybe this is where we could really see a training effect in a field where I think we unfortunately know there are very few types of training methods, if any, where we continuously see that they have an effect on therapist improvement. Right? We have ways of training that are long established, but there are very few manipulated training studies, or at least ones that have been replicated, that said if you teach in this way, you will see that a therapist gets significantly better on the thing you're teaching. Right? We just haven't been a field that has matured all that much in testing our training ideas. And so this would at least be one way to take what you learn. First of all, there's a certain level of humility you have to allow your performance to be measured and to get the feedback, right? And if you do that, and then your training becomes more targeted, or your decision making about what patients you see becomes more um, pointed, maybe we will see an overall bump in the field in terms of how to train, how to practice, how to get our patients to the right providers, because we know the provider matters. But we know the provider still doesn't explain 95% of other variants, right? So it doesn't mean that it's unimportant to learn treatment types, or it's unimportant to learn, um, common factor processes. All of those things are still really vital, right? Because therapists still do things in the room that we can learn about. Oh, this is what makes you effective, right? That's the other area this research has to take us. Is it's one thing to say a therapist is really good in this area. It's another thing to say how do they do it,
Right.
and is it generalizable, or is it specific to their style and their charisma and their attitude and their personality? Um, and that's another thing that we want to think about in terms of training is how do you bottle the things that we learn, um, that therapists use or parlay into exceptional effectiveness.
One of the things when it comes to humility that you were talking about, the person who's more humble is more likely to seek out training, get feedback. But I was also thinking about the effect of sort of Jesse Owens' work, former guest of the show, that
Yes.
that that also in session, if I'm more humble, I might be more willing to listen to my client and be more flexible
Yeah.
and learn from them. That right. So like
Exactly.
that you could see
Exactly.
that could be happening at both levels, right? In session, if I'm more humble, then I'm probably going to be more responsive, right?
I think responsiveness is the perfect term for it, right? Yeah, cultural humility within Jesse's multicultural orientation model being one of the pillars of that orientation, I think it's a perfect way to think about it, right? It's like if I'm humble, I don't presume I have the answer. I'm not surprised that you and I might have a tension or a disagreement, and I'm open to hearing your take, your perspective, and I'm open to working with you to collaborate on a solution, I think that becomes just a meta facilitative interpersonal skill, right? Which is just like a willingness to listen, a willingness to learn from the patient, to see it as a two-person bidirectional psychology. And then you start, we're all the way back to square one for me, which is like, how do you take self-concept and interpersonal relationship and negotiate it for good? And I think, anybody who's talked about alliance and alliance ruptures, you constantly think of the therapeutic relationship as having to be negotiated because it's two sets of people with unique needs, histories, talents, shortcomings. And those will come together and create dyadic indices, right? Indices of hopefully often attunement, but sometimes misattunement.
Right, right.
And the misattunement could be I didn't listen, or the misattunement could be cultural, or the misattunement, could be I offered this, but you told me you really didn't need that. You needed something else. And the humility, I think, sort of opens us up to see moments of misattunement.
So, getting back to what you said a while ago about in your match study that people of color, that this matching seemed to matter a lot. So, that was still matching on that like primary domain.
Exactly. It was still matching to problem, and they still didn't know they got matched.
So for people of color, matching with a therapist who has particular effectiveness in that primary problematic domain,
At least their primary problematic domain. Yep.
that
Yep.
really mattered regardless of
It
those
doubled the
patients'
size of the match.
severity.
Exactly. It doubled the size of the match effect as an independent moderator separate from severity. Yeah. Right. So there seems to be something about the experience of working with a clinician who is historically effective at treating your problem. You don't know it, but still they met with that therapist, and that therapist we knew was very effective. There was something about that experience that helped those people in particular, people with those identities in particularly, because they must have had some challenge. They probably had some challenges in finding a therapist, working with a good fitting therapist, perceiving a therapist as meeting their needs, and it was helpful.
I think
But
that
we,
so
yeah,
I wanted you, but I think that there's lots of work on people of different, like looking at socio-demographic variables and matching with therapists, and it's mostly a dud, right? So
it's
that
mostly
there's the
non-significant effects of matching to identity. Yep.
right. So, and I think that it's an interesting thing because like when I'm teaching, like one of the undergrad courses that I teach, oftentimes this comes up and people are just like, I'm sure that this is like, this must matter. And it's sort of like, well, the data don't really support that, but
Yeah.
this is doing so. I just think that this is really interesting.
Right. It's interesting, and we want to take it further, and we have. So we've now basically done sort of a rinse and repeat of our entire sequence of learning about therapist strengths and weaknesses, finding out if patients and therapists and administrators would want to hear about that information for treatment decision making purposes, and testing whether matching matters. We are doing that now with identity. So, in two different ways. First, we'll talk about race and ethnicity, right? We are basically saying the only thing it takes for a therapist to have strengths and weaknesses is at least two domains of measuring on something. So instead of looking at the 12 problem domains, we are now looking at whether therapists differ. If a therapist's average patient's outcomes differ depending on the race and ethnicity they identify with. And so it turns out that therapists can also have strengths and weaknesses, not only in what they treat, but who they treat. So for some therapists, their average patient who identifies as a person of color gets significantly better than when they treat their average patient who's white, and vice versa. And so that too can become a match variable. And we have now shown preliminarily, this is with retrospective matching, just did it happen, not did we intentionally manipulate it. But we have shown that when a patient got matched by chance to a therapist who their historical data told us they were better at working with people of color than with white individuals. When that happened, or in the other direction, did they have significantly better outcomes? It turns out that they did.
Right.
And
And
so
so
we're getting
these,
ready to publish those data with, again, Alice Coyne, James Boswell, David Krause, and myself. But this is just, it's inspired by learning that matching to problems was very relevant, in fact stronger for people of color. It's inspired by that, but then we thought, why not just directly test whether some therapists do better with certain identity groups and have that be not only a reaction to our own matching work, but an antidote or another way of thinking about matching on identity that is different than the findings that you mentioned that are non-significant, right? So it's not about matching just because we both share an identity. It may be matching in a way that pertains to identity, but it's because the patient identifies a certain way, and you as the therapist historically do really well at treating patients who identify that way.
right. Yeah. So, and
And
that's,
so
I
it's
think that's
going to
the,
be a parallel match system. Yeah,
right. So I think that's a point to emphasize, which is these are not necessarily therapists of color, or they're
exactly.
not
They might be,
matching.
but they don't have to be. Yep.
Right, right. They could be, but they don't have to be, right? So you could certainly imagine a case where you'd have therapists of color who actually have worse outcomes with
For
patients of
some
color.
reason, when
For
they
some,
work with people of color. Yep.
right.
Yep.
So
Yep.
it's just right. Okay.
And then we of course want to see if we double match based on problems and identity, will we
Right.
get an even bigger effect? So this is the sort of things that are coming. We've gotten most advanced on the race and ethnicity question, but my graduate student Avery Gaines, her dissertation is also focused on doing a very similar thing for sexual orientation.
Right.
And so, and we've already established that once again, therapists can have within caseload differences. So, relative to themselves, they can have strengths and weaknesses depending on the sexual orientation that their patients identify with.
Mm-hmm.
Yeah.
Yeah. So are
And
there?
so,
I'm sorry. Go ahead.
yeah. No, I was just going to say that's just a different way of tethering um, evidence-based matching to identity that isn't the thing that a lot of people are disappointed in hearing, my students as well, that if you just put people with the same identity together, they must get, they must prefer that, they must get better, and you're just like, they might prefer it, but they don't necessarily benefit from it, right? But that also tells us there's so much more to that than just we share an identity, right?
Right.
In terms of like cultural connection and so forth, and his personal experience connection. We should have never expected that this sort of just identity match would be a boon to patients' improvement.
Right. Right. And so are there any other, because I'm thinking about, so like what would be the most robust match variables, right? Match characteristics. And so, I'm one of the things that pops into mind is personality, or, even it could be interpersonal problems or something in that sort of world.
Yeah.
Are there other sort of, characteristics that you would think about matching that you're sort of like, oh, maybe, that are sort of like, oh, I think that could be something where there's a lot of value.
Yeah, it's really interesting. There's been this question of like patient aptitude by treatment interaction that's been around for a long time. Like the first way to think about personalization was like, who are the patients who would respond best to CBT versus IPT, or medication versus psychodynamic, or something like that. And I think that hasn't led to many replicated findings. There are some that are certain attachment styles would do better in cognitive behavioral therapy, certain others would do better in interpersonal therapy or dynamic, but nothing that has really sort of stood out and become a replicable finding that people start to implement. But I do think Rob Derivius's work on having a personalized advantage index, so basically using machine learning and predictive analytics to say, if you have this constellation of presenting characteristics, then it is much more likely that this type of treatment that you'd be better suited and more likely to respond to this type of treatment than this type of treatment, or to a medication versus this. I really like the predictive algorithm or analytic method because it takes a constellation of patient symptoms into account versus saying, is there one patient factor that we can match to treatment type? And so, inspired by that, I get to work in here. One of the newest things that we're doing is we are creating a patient treatment fit variable to try to leverage clinically the between therapist effect. And I'll try to be brief on this one. But basically, we're trying to think of this as an efficient, simple match system that clinics might be well positioned to use immediately, that can capitalize on just learning which of your therapists are highly effective overall and which are sort of less effective. And if you knew that, then it becomes a question of resource allocation, meaning who are for whom, for which patient should you most preserve openings on a caseload of your most effective therapist? Which patients need to see those highest overall general performing clinicians? I'm not talking about the 12 domains now. Which are the patients who most need those therapists to get better? And we are developing this predictive analytic, again, calling it inspired by Rob Dervis's work on the personalized advantage index for treatment types. We are doing it for provider type. And we have some really interesting preliminary data that basically will tell us there are certain constellations of presenting characteristics for patients that would make them statistically more likely to improve if they saw a therapist in sort of the top third of the sample. And we're doing this in a really efficient way. So we only have sort of two categories at the moment. You're either a patient who needs a high performing therapist, or you're a patient who would get better or who would improve to the same degree, hopefully get better, whether you saw a high performing therapist or any other therapist. And again, it's another version of like, first of all, if you wanted to do this now, you wouldn't need to have a multidimensional outcome measure. You could just have one measure that says you are highly distressed or not. And as long as you're collecting some data on patients in that way, then we could find out at baseline which of those patients should you be preserving your highest performing therapist for, and which patients could see any of your therapists. It's not based on within therapist strengths and weaknesses. It's simply based on who are the overall most effective therapists in a given network or sample. And so, we think of this as sort of a way of doing like a day one type matching before a clinic might be willing to also consider learning about therapist strengths and weaknesses based on problems or identities. At least this way, from a resource allocation point, you could help say, I know that these are the top therapists in my network, and I don't want all of their openings to get taken up by patients who would do just as well with any of our therapists. We really want to preserve that space. So to your question, to us, that's another match idea that we're really excited about, that again takes constellations of patient characteristics into account as opposed to just looking at individual variables in interaction with treatment packages or something else.
Mm-hmm. Mm-hmm.
So I hope that has a lot of bang for the buck as well.
So one of the things that stands out is that at the beginning when we were talking about what is the between therapist effect, and I know we're talking more about within therapist effects now, but we said 5%, right? So what
Yep.
seems like a small percentage of the variance, but the effects of your match study, or the effect size of whatever it was, 0.75, did you say? So
the between group effect 0.75. Yep.
Yeah, so it's
Yep.
huge. So I
Yep.
think that I just sort of want to bang that home, because I think that sometimes we see this, these effect sizes, 5%, 7%, whatever it is, and we think, oh, well, who cares, right? It doesn't really matter.
Right.
But to an extent, what your study is saying is like, there's a tremendous amount of bang for the buck in that in a way that 5%, it's not intuitive in terms of what that actually means.
No, exactly. I think a way that helps me, and hopefully when I talk to students, it's like, the idea of like what percent of variance and outcome is explained by a variable, that comes from correlational predictor research, right? And hopefully if I say the therapist explains 5% and you're like, oh, well, what does that matter? Hopefully if I say, well, the therapeutic alliance, do you think that's important? And somebody's like, well, yeah. And it's like, well, that explains about 7%, right? It's like, and the best we can do is usually like empathy and therapist empathy and goal alignment. Those are like 10 and 11% meta-analytically, right? So it's just, if people can just appreciate that the best we can do is explain somewhere between 5 and 10% of variability. The only thing that tells us is that variable matters to try and do something with it. Then the doing something with it, like leveraging it in a match intervention, that can explain far more variability, right? Because you've taken a meaningful variable, you've created a type of intervention, although in this case, the intervention is simply who do you assign a patient to? And then you try to sort of capitalize on that effect purposefully, pointedly, and then you see a bigger amount of variance explained by the intervention.
Hmm.
And so I think that's the process of taking a predictor or a process outcome study that says, okay, it's explaining a small but meaningful amount of variance. But it's like, can I leverage it intentionally and do something with it that makes it more potent?
The way that
Right.
I often explain it or talk to folks about it is like, is sort of between teacher effects. So because we've all been
Yeah.
in years of schooling, right? And so that the between teacher effects are about the same as the between therapist effects.
Yeah.
And that like just, you know, have you ever, think back to your time in classrooms. Have you had some teachers that were awesome and some teachers that were terrible, and a whole bunch are kind of average, right? It's sort of about the same thing with therapists. And what you guys are doing, which is super cool, right? Because with teachers, I mean, when you get to university, you can pick and choose somewhat, but
Yeah.
most of the way through, you just get assigned to them. It is what it is. But what you're doing, which is very cool, is saying, let's find the best teacher for you, right? And
Yeah.
let's match your style of learning, your challenges, your whatever it is. And
Yeah.
let's match you to that best teacher. And
Yeah.
that if you, I mean, if you actually think about that autobiographically, that man, if I had, the class that you struggled in geometry, but if I found the best geometry teacher for you specifically and put you in there, you'd probably do pretty well and learn a lot.
Right. Right. And I love that. I mean, thank you. And I love that summary because part of what we talk about is, like 180 degrees of personalizations. For so long, when we think of personalizing, we think of getting a patient to the right treatment or the right intervention, right? But there's also ways in which we can personalize not only the patient to the right provider, but also the provider to the right patient or the right training experience, right? Like whether it's a teacher or a therapist, it's like after training we tend to just think you can do what you do, right? But just like with our patients, we should be thinking about everybody needs some level of personalization in their training or their experience or their professional development. And so that's been what we've been trying to talk about, is like expanding the notion of personalization um, to the provider as well.
So are
Yeah.
you okay with time? I know I could sort of talk.
Yeah. Yeah.
Okay.
Yeah.
Okay. Great.
Yeah.
I have about I have 30 questions that I'm not going to get to because this has just sort of gone on. This has been great. I wanted to talk about training.
Yeah.
So, I just did a podcast with Tony Rumanier, who's the big
Yeah.
deliberate practice guy and his work
Yes.
and all
I know
that sort of
Tony
stuff.
well.
Yeah, of course, of course. Um, and so we happen to be in the middle, my home program, we happen to be in the middle of reaccreditation and all that stuff.
Yeah.
And so these sort of things are hitting simultaneously. And I'm sort of like, man, I sort of think we really need to rethink how we do training. Um, so for you, where do you sit on that? If you were the czar of training, even if just in your particular program, what would what do you think training would look like?
Yeah. It's a great question, and it would take a really long answer. So I'll try to give a brief answer. But I mean, I would combine a lot of things. But we actually just wrote a chapter for a book on training that was edited by Louis Castonguay and Clara Hill. Um, and our chapter focused on a model or a framework that I've been developing for a while now, over a decade, called context responsive psychotherapy integration. And this model essentially tells us that it's sort of an if then way of thinking about psychotherapy, right? It's like if that we all need to have some level of first step responsiveness to a patient, right? And it could be based on therapist strengths, that these are the patients you see or patients get assigned to you. But it could also be on like offering a rationale for the work and how one might change, right? And the idea is that this first step responsiveness is to try and find a way for you and your patient to get off on the right foot. And part of what I think you would need to do to train in that, to facilitate that, is to learn multiple theoretical approaches at least a conversational level, right? So that you have the ability to offer treatments and rationales and principles to meet a patient's need, to have a patient say, that one sounds good, that one doesn't, or like, oh, I want to explore that a little bit more. And so I would spend a lot of our time training. One part of training would be to get people to be more conversational on a variety of overarching theoretical models of change. That doesn't mean you try to teach people 20 manuals in graduate school, right? But it does mean you don't only teach people CBT for 5 or 6 years. um, and so that's one part. And then the other idea of context responsive responsiveness that would come later is that we know empirically that when certain things happen in therapy, that they will predict a worse outcome for a patient, right? So when there's an alliance rupture, when there is resistance, when somebody's expectancies for improvement wane, when there are cultural misattunements, these are big ones, right? And if we know that those occurrences happen, that they pose a risk for poor outcome, and that they're relatively common occurrences, we've already established some evidence-based ways to depart from what you're currently doing and instead use these pointed strategies that are useful and empirically supported for improving, repairing ruptures, restoring hope, getting more culturally back on track and aligned, addressing and resolving resistance. And I think we should be spending a lot of time in our training, in addition to getting conversational on a variety of theoretical approaches, we should be training people to learn what are these key markers that are risk factors for poor outcome, and what are evidence-based strategies for addressing them. And so these sort of modular if-then trainings, I think, so actually James Boswell and I wrote about these in our deliberate practice for cognitive behavioral therapy, where it's like, when do you have to take your CBT and put it on the shelf, at least momentarily, because these other things data will tell you are more likely to be effective in resolving the rupture, resolving the resistance, etc. And I just don't think we spend a lot of time in training on these sort of modular if this then that, if this then that, even though a lot of times in supervision students are coming to us saying this thing happened and oh shit, I don't know what to do with it. And so I just would want, we have a database and it's growing and it should always evolve. The context responsive psychotherapy integration model should always evolve as we learn more if markers and then responses. But those are the two components that I would want to put, that we wrote about as sort of training in a new key. Train people to get off on the right foot by being able to be conversational and thinking about a variety of ways people change, and find one that suits the patient. And getting off on the first step could just be seeing the patients that you already know you're good at treating, the therapist effect stuff. But really, this idea of ongoing responsiveness to the moment or to the context is like learning, perhaps through deliberate practice, how to be more effective at addressing negative process, if you will, or disruptive process.
When I did the podcast with Catherine on alliance ruptures and repairs, and sort of, I was familiar with literature, but in prepping, you really do these deep dives, and then you have this long conversation with this person. Sort of through that experience, I sort of walked away saying, why the hell is this, like, this should be a part of every training program? Because one of the things, in her work that becomes clear is alliance ruptures, these are not outlier things that happen every once in a while. These are normal parts of the process. Like, it just is going to happen very frequently. And that as therapists, when you're in training or even practice, they're scary, right? It's sort of like, oh God, what do I do? Now we're not on the same page and I don't know how to handle it. And I feel like my client's being defensive, or maybe I'm being defensive, right? All these things are happening and it becomes this oh shit moment but it's normal. So instead, if we train it as, this is a normal, like, expect this to happen. And this is actually therapeutic in and of itself. This is one of the values of this.
It's an opportunity.
Yeah. Just like you said at the beginning, this is this interpersonal relationship you're having. And so part of our training being to, instead of don't try to avoid this. I mean, don't be a jerk, but don't try to avoid this. Accept it when it's there and see it as an opportunity. And we can actually, there's really nice training that can help you to work through this so it actually improves the relationship, improves outcomes.
Yeah.
And I was sort of in reading that, or sort of like doing that deep dive. And actually, when I teach this fall, I'm teaching it, and sort of going to dig into it because I
Great.
was really,
Yeah.
convinced. But anyway, so it just really strikes me, and that's exactly
Yeah.
what you're talking about. And you're more
Yeah.
sophisticated about it. And you're saying here are a handful of places that are just normal, challenging parts of any therapeutic experience,
Yeah.
trans theoretically,
Yes.
that we
Yes.
need to train folks to be able to respond adaptively to these, and it'll help in all sorts of ways.
All exactly. And the yeah, so part of the CRPI model is like trying to think of common factors a little differently. They're not just trans theoretical principles, but rather they're things that happen commonly,
Mm-hmm.
right?
Right.
These things will come up in your work, and it's not because you made a mistake, it's not because you induced them, it's because two human beings are having an interaction that has to be constantly monitored, negotiated, and experiences checked on and discussed. And so yeah, part of that, you know, oh shit moment, I think, is often this was pulling me away from what I think I need to do as a clinician, which is stick to the treatment. And what I would want training to do is to really underline sort of the interpersonal principles. It doesn't mean you have to be an interpersonal therapist,
Mm-mm.
but just understanding that one of the things that's always available to you as a clinician, and it's empirically supported as being helpful, is meta communication, right? Talking about what's unfolding between you and the patient right now. And I would just want to teach people that early so that they don't think, I have to show you this video. It was terrible. It was the worst session. I didn't know what to do. It's like you always have something available, which is to say, I'm sensing right now that we're having some tension and I'm not quite sure what to do with that.
Mm-hmm.
Maybe it's worth talking. Like you always have available to you the ability to meta communicate. Like as a therapist, you should never feel like you don't have anything to say or do
Mm-hmm.
because you can always say, I'm experiencing right now that I'm not quite sure what to say or do.
Mm-hmm.
My experience of us right now is leaving it so that I'm not sure how to proceed. And I would love to talk to you about that because I want to get your take and get on the same side.
Yeah, and that was one of when I did one of these with James Boswell. One of the
Yeah.
major
Yeah.
takeaways that I had in that was sort of just like the bring whatever's going, just bring it into the room, right? Bring it as part of the
In this
process,
room.
bring it up with the client,
Yeah.
have it be part of the conversation.
Yeah.
That there's so
Yeah.
much power in that.
Yeah. If a supervisee can tell me I was feeling stuck, my first response is going to be, well, did you tell the patient that you were feeling stuck in
Mm-hmm.
that moment? It's
Right.
not that it didn't have to be like, you were chewing your nails and couldn't wait to talk to your supervisor because you didn't know what to do in that moment. It could just be you shared your experience in the service of relationship ruptures being corrective experience opportunities.
Mm-hmm.
And if we just are able to sort of get that in the vernacular of people, without having to, necessarily disparage treatment packages or names of orientations, because I don't think that's going to do us any good either. To me, it's really about learning to speak different languages with your patient and then understanding these core common principles and risk factors and ways to address them. I think if you were equipped with that, if we did a manipulated training study, I would think that if we train that way, I'd like to believe, or at least I'd hypothesize that that would outperform our typical approach of just spending a year in a certain person's team who does ACT or this or that or CBT or IPT or PD, whatever. You can collect those experiences, and I think those will help you become more conversational about theory and about change processes. But I think if that's all we're doing, then people start to believe that treatments treat people as opposed to people treating people. And in therapy, it really is people who treat people. We use strategies, we use techniques, but we're not just prescribing something and hoping that those skills stick. I mean, some people do. Some people believe in that approach. And that's okay. I'm not even putting that down because part of our research on therapist effects is also showing us that some therapists will use cognitive behavioral therapy really effectively and others won't, and vice versa. Some therapists will be really good at using more open-ended exploratory dynamic supportive therapies but you try to get them to do a CBT protocol, for example, and they'll be clumsy, right? And so also through training, I think what we can be learning is what do we personally use well? Not only who do we treat well, but what do we use well? You know,
So
I don't like it. I think if I was asked to do certain things, I would just be clumsy at it. Right. But if you ask me to do other things, I might be more verbally fluent, more hope inspiring, things that go into the FIS construct. That might just be more natural for me if I'm asked to be more Carl Rogers like than, more Beck like, to be overly simplistic about it. Yeah.
So before we wrap up, let me take a real quick left turn. You did a little
Yeah.
bit of work, some work looking at different, like the different mechanisms of change for different therapeutic approaches.
Yeah.
So like this idea of like that outcome. So if we,
Yeah.
if we're doing cognitive therapy and interpersonal or something like that,
Yeah.
that the
Yeah.
mechanisms of change, like they might be equally as effective, but the mechanisms of change are different. Could you
Yeah,
give us a real?
yeah, we did. It was a really cool study with Alice Coyne where we did these competing mediator study, and it was basically born out of a trial where we compared CBT alone versus CBT integrated with motivational interviewing, so very client centered like, um, and at post treatment there was no difference, right? So there wasn't an additive effect of integrating motivational interviewing into cognitive therapy. There was a cross follow up, but we'll leave that to the side for now. Just for the idea at post treatment, we thought, well, that's normally the point at which people will stop looking for mediators or mechanisms, right? There was no main effect of treatment to mediate. Statistically, though, you don't need a main effect to find mediators. And it turns out that in that trial, the CBT clinicians were very good at promoting patients' trusting reliance on the therapist direction. So they were just being really good teachers, like CBT clinicians often are. CBT clinicians are often friendly and more dominant in the approach of teaching or nurturing or taking care of or giving skill. And they promoted more patient trusting, following, or reliance on that. And that transmitted or that was then translated into better outcome in CBT. Whereas the MI therapists, they engendered in their patients more than the CBT group, greater sort of client agency, which is what the MI was intended to do for those patients. And that translated into significantly better outcome in that condition relative to the other. So it was basically both groups were promoting something in a really effective way that treatment was supposed to. And that significantly led to better outcomes when it was higher versus when that process was lower. But it also wiped out any main effective treatment, right? So we have different paths to getting to the same place. And if we can align the therapist delivering the treatment with the mechanism of that treatment and that goes well, that's one way to get a patient a better outcome. But you can see a totally different path for a different patient, and then it becomes about getting patients on the path that they're most likely to respond to. But it was so interesting, and I wish that paper was read and cited more because it was really meant to be like a statistical showing of like, just because you don't have a main effect doesn't mean you can't find different ways in which a treatment promoted better outcome. And then we showed it, and we showed how those two paths suppress the main effect. And so whereas most people stop and they just say, well, we didn't really learn anything unique. We just learned that two bona fide therapies are equally effective. So what, we knew that. But as it turns out, if we still do mediator analyses, we actually found out the way, or at least one way, in which CBT alone helped, and one way in which CBT integrated with MI helped. And so you have these nice sort of theory specific mechanisms that were supported.
Well, so it might, I don't know how much it gets cited, but when I learned about that work several years ago, like it really I had a light bulb moment. And that's why I brought it up, because I just sort of was like, this explains so much, right? This whole sort of dodo bird verdict of like sort of the generally speaking, what treat the different orientations, there aren't really differences in terms of outcomes. it's sort of like, well, the different approaches are sort of working on, the way I think about it is like they're
Yeah.
working on different systems. And
Right.
so they're
Right.
all going, so all of these systems matter because we are sort of, all these systems are part of a whole person. And so that you can impact these different systems within a person by these different ways and get sort of the equal outcome.
Yeah.
And when I was talking to Bill Stiles on this podcast, he was talking about sort of a similar, and I'm going to butcher this, but sort of this idea of that, yeah, if you just look at symptom reduction or quality of life improvement or whatever, they're all about equal, but the
Yeah.
actual experience of the human being and what changes in the human being probably differs between the different approaches.
Right.
And I
Yeah.
think that, when we look at these other characteristics, sort of like what you guys were, right? So like, and I just think that that's a really, nice and more sophisticated way of thinking about these different approaches that we use, and sort of, they're all the same. It doesn't matter. I sort of think like, I mean, sort of, but that just seems too simplistic. I just sort of like,
Yeah.
I think you guys sort of cracked the egg open a little bit, and it really at least influenced how I think about the different approaches and their impact on people and people's experience of them,
Yeah.
and really made it much more three-dimensional.
Yeah. And that's really well said, right? Because part of it was just like, we maybe we can move out of the trialist mentality, is like
Right.
we're looking for comparative effects. If they're not there, there's no reason to go looking for mechanisms because there was no effect to explain. And it's like, no, we can still say, but what was helpful in CBT that
Mhm.
made it comparably effective to this? Or what was helpful in CBT slash MI that made it comparably effective to CBT? And then it does allow us to continue to unpack, add nuance, think about ways that if I'm going to choose this path, well, then this is a variable I want to, as a clinician, to cultivate. But if I'm doing CBT alone, this is a different type of variable I'd want to measure and cultivate. And it gives you an option as a therapist. It gives you more insight into theory specific pathways to change, all that can then sit aside alongside more common factor research that says, irrespective of what you're doing, these variables will matter. Like the alliance in both of those conditions was predictive of outcome, right? Of course. And so then, yeah, it becomes more three dimensional, it becomes more nuanced. And it's just like all in the service of understanding sort of how people change and knowing that there are multiple ways to arrive. And as you put it, at different outcomes, even,
Mhm.
right? Certainly at change. But it also depends on what outcome is most important to the patient, right? If they really want to improve their self esteem, that is different than reducing their symptoms. And you might choose to do CBT MI because MI is really focused on self efficacy and self esteem. But if somebody's just like, I just want these symptoms to go away, I just have to stop panicking, you might be like, well, CBT, I know if I can get them to if I can get them to sort of trust me and rely on my, um, rationale and follow the techniques because they believe in them, then that will be the most effective way to go. Which brings us right back to sort of personalization in what we choose to do, and responsiveness when it gets off track. And I think these are just the two big constructs that go hand in hand when we think about individualizing therapy in an evidence-based way.
So one thing I ask everyone when I chat with them is if they've had any pushback to any of their work.
Yeah, I mean it's a great question, and I think the you know not really in terms of like these going back and forth in journal articles with commentaries and rebuttals, not really, and not even with sort of audience members in a lot of what we're presenting. I think the biggest potential pushback, I think, has been from the therapist who worries that the kind of narrative that could come out of the match work or the therapist performance profiles work, is that it could affect their livelihood, right? Is that it really could, that in some ways they could lose their job, or lose their ability to have enough patients on their caseload. And we have been aware of that from the beginning because we did a lot of qualitative research, interviews, focus groups with therapists. And so from the beginning, we have said, we don't want that message to come out. That's not the intention of our work. And so help us understand the messaging, help us understand how this has to be contextualize and not oversimplify to just say, well, if you get a strength, you should do that, and if you don't, you should stop. Like, we never intended it for to be that. So I hope we've been, because we've been involving therapist stakeholders from the beginning, I think for the most part we've mitigated ahead of time the potential pushback that would be there. And we also we've tried to be very clear about, right now we're just talking about problem-based matching. It's not the only thing. And we aren't trying to overstate the findings, right? There are moderators, there are shortcomings, there are limitations, and so hopefully that, haven't really had a lot of pushback, on the ideas.
So what do we do with the 4% of therapists or so that suck?
Yeah, I mean, that's a yeah, and it's like, first of all, I think we'd have to parse the research more carefully than we currently do, because again, we have 4% of people who are either ineffective or harmful or some combination across the 12 domains. So the ones who really suck would be, or the ones who are harmful would be the real ones to find out about.
So that's less
And
than
that
4%.
that would be less than, if you're okay with just this person is kind of ineffective or more average. If you're okay with that, at least at least do no harm kind of thing. That's a different subset of that 4%. But yeah, you're right. There's probably 2% of people who are actually harming their patients.
Regularly.
And so regularly. And that is a tough thing to answer. But if we really wanted to face that problem and we really wanted to live up to the do no harm oath, I think we'd have to be willing, systems would have to be willing to act on that. It doesn't necessarily mean, well, I guess it depends on the time at which you found that out. Getting back to training, like, how long do we need in training to learn that somebody's becoming pretty regularly harmful? And then, that's an open question, because it's quite possible there are some people that should just continue on into research or teaching or another field. But I'm sure many people would push back on that idea to say that it takes time, and 5 years of graduate training isn't enough to trust that somebody's harmful, right? So, but even if we learned it later in a career, we might have to think about, how do people reroute their interests and what they do professionally if they start to learn that they consistently produce harm, and maybe even after they go through trainings it doesn't change. Yeah, I mean, the answer is, like, it would be great to help those people change direction in their career, but that would be pushed back on for sure.
Well, honestly, your number's very low.
It's
Generally when I
low.
have conversations with
Yeah.
people about this, I'm trying to think of uh, there's been work done sort of on these things, and usually the number's higher than 2%. So I think when people sort of talk about the concerning therapists, so that this is a really low number. And what I always sort of think about again, go back to teaching, right? Like, we all had
Right.
teachers who were terrible.
Yeah. Yeah.
And that it just makes sense that you're going to get people in any field who aren't going to
Yeah.
be good at it.
Right. And if we go back to the difference between and within, right? At a between therapist level, yes, there are just some therapists whose average patient is going to get worse, or is not going to get much better. Right. Which is, I just want to be clear that what I was talking about with the 4% is just the people who had no strength across any of the 12 domains. Right. So 4% of people never had a strength. And then we were saying some sub percentage of those might have multiple or many areas where they're harmful.
Right.
That's why it's getting lower. But you're right. If you just think of it in terms of overall performance, the number is probably higher, that there are therapists out there that we might say suck.
Right.
Yeah.
But I mean, I think though that your approach to it is it's more nuanced. So because of that, it's actually a little more generous, maybe even a lot more generous.
It's a little more generous,
but that's okay.
It gives you an opening. Yeah, it gives you an opening to capitalize on a strength, or at least an area where you're average.
Yeah, and why shouldn't we, right? Like, I mean, these people are in the field. Wouldn't it be nice to be able to reduce the amount of deterioration, increase the amount of improvement? And then there's only, 2 out of 100, and we're ballparking these numbers. 2 out of 100, and if there's only 2 people out of 100 that we really need to, like, try to help, and or if that doesn't, that's pretty optimistic, I feel like.
Yeah. Yeah, counsel out of the
Yeah, out
practice
of the
area.
profession.
Right. Yeah.
Um, so,
Yeah.
so you sent me a few links that I will include. Are there other resources or other places where, for folks who are listening, who you think
Yeah.
who would want to learn more about what we're talking about, that you want to direct people towards?
Yeah. Well, what I'll say is the two links are to they're the project pages, both for the trial we talked about and the implementation follow up to that. And part of the reason I sent you those is those pages also have links to any articles that have come out related to those data sets. And so for the trial, we've actually done a fair amount of follow up
Mhm.
studies as well, some of which we talked about. So it's kind of a one stop shop for clicking on to get to articles. But because you brought it up, I might suggest for those who are interested reading that chapter we have on context responsive psychotherapy integration. So training from that perspective. And again, that came out recently in a book, an edited book by Castlegate and Hill. And I'd be happy to send you a link to that or the reference. And for anybody who is interested in that part of our chat about training, um, it would flesh out some of the ideas that I brought up at an overview level.
Yeah, that's perfect. Yeah, I will link to the to all of that. So, Mike, I can't tell you how much I appreciate this. It's been
I really
wonderful.
enjoyed it. I thank you for all the kind words and for having me.
Thanks so much for watching. If you found it helpful, please like the video and subscribe to the channel. I'll see you in the next video where we continue exploring the science of psychotherapy and applied psychology.